have to do a literature review and follow the literature, because there's a lot of changes which keep on happening in terms of the literature. And if we do not keep a track of that, there will be a problem. So why do we do a literature review? Of course, we want to change our practice. But before we change our practice, we need to know whether this article that we are really reading is worth changing our practice or not. So we need to understand about whether the article is valid in terms of whatever they have found is something which is close to the truth. The next, of course, issue will be that suppose this is valid and whether it is applicable to our setting or not. So if we have some intervention which is not possible at our level, so somebody tells you that you have teplizumab which is available, which can increase the latency of the diabetes by a few weeks, you would say, okay, but then the cost is prohibitive, it's not available, then it may not be generalizable to our population from that regards. Now, whether this represents a novel work and whether we should really change our practice or not. So we'll try to put these 3 papers on test and how they can change our practice and how they can improve or in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources and courses related to pediatric endocrinology. We have got our fellowship course and a diploma course. We do run a number of grand rounds, postgraduate lecture series and journal clubs to highlight pediatric endocrinology. There are multiple publications which are available and the mobile application which really helps us guide in terms of evaluation.
So this paper looks at DEXA-based fat mass with risk of worsening insulin resistance in adolescents, and this is a prospective 9-year temporal study. Why do we need this study? Is because as even in the predictors of metabolic complications in obese children that was done at our center, we found that almost as many as 40% subjects are free of any metabolic complications, despite obesity becoming more prevalent in the last few years. And our study shows that children with obesity who were picked on screening for dysglycemic complications had a better outcome in terms of who went on to develop type 2 diabetes. So what we need to know, or where our lacuna lies, is we still don't know the factors predicting dysglycemia in children and who is more at risk. We don't know what should be the ideal age at intervention, even in the absence of complications. So even on screening, if we find no complication, is there any other surrogate marker that could guide us about the risk of developing dysglycemia at a later age? And if there is a certain age, what should be our target of treatment, or how aggressively should we intervene in them to prevent long-term dysglycemia? And this is something that the paper has probably tried to understand in terms of it is looking at the body fat percentage to estimate your long-term risk of insulin resistance and dysglycemia. So how it was done is it used the ALSPAC cohort, which is somewhere around Bristol. So every delivery that was happening around there, the children or the mothers were enrolled at the time of delivery, and these children were then later followed up at 15, 17, and 24 years, at which ages the DEXA scans were done. Along with fasting glucose, fasting insulin levels, and insulin resistance. Fasting glucose more than 110 milligrams per deciliter was taken as hyperglycemia. Fasting insulin greater than 11.7, it was again a marker of hyperinsulinemia in these children. And a HOMA-IR resistance of greater than 75% was considered significant, whereas less than 75% was considered normal. While we know that HOMA-IR is a surrogate marker of hepatic insulin sensitivity, there is another SPICE index which takes into account cholesterol levels as well, and it has been used as a surrogate marker of whole body insulin sensitivity in this study. So the correlation that it has seen with several clinical parameters is the insulin resistance. Again, as you would expect, with increasing BMI, your insulin resistance will increase. However, the whole body insulin sensitivity did not match very well with the clinical parameters in this study.
Just one second. So, HOMA-IR is a marker of insulin resistance.
हाँ.
And spice is a marker of insulin
Whole, अच्छा, whole
sensitivity.
itself, yes.
So it's the
Okay.
opposite.
हाँ.
So when you
Yes.
are saying it's minus 0.9, what you're basically trying to say is that if your BMI is going up,
It will, sorry.
your
हाँ.
sensitivity is going down. So it's actually showing a very good correlation.
Good. हाँ.
Because it's a negative correlation, but then it's the other way around. So what you're looking basically is that there is a moderate correlation. I'm sure the P will be significant. You have given the numbers.
Numbers of
Number of the children.
3,000.
So it is a large study.
100.
So 0.37 would be a big number as far as correlation is concerned. But minus 0.9 is much more significant.
Yes.
So I think that's something which gives you, which is expected. That as your BMI is going up, your spice should go up. But what's not expected is the
Lean
last
mass.
one. How does the lean mass have a negative correlation? So just by using cholesterol, they are adding cholesterol into the IR, HOMA IR.
So they've not used HOMA-IR. It is a complicated equation which takes into account the triglyceride and triglyceride, LDL levels, and BMI.
Okay. Which I think is a probably might have been validated somewhere, but I will be very questionable about that. But just by looking at lipids, how can you talk about that this is something which is a marker of whole body sensitivity? So that will be with a pinch of salt. What do you think about HOMA-IR as a marker of insulin resistance? What is HOMA-IR?
It is looking at your fasting glucose and fasting insulin levels, and based on that, it is trying to estimate the amount of insulin required to maintain.
So it's basically what it's trying to say that this is your fasting insulin and this is your fasting sugar. So then people will say, okay, if my fasting sugar is high, my insulin should be high. And then you try to see how much is the correlation in that.
Okay.
So it's a crude marker. What is the best marker of insulin sensitivity?
So hyperinsulinemic clamp test may be a better marker.
Basically give insulin from one side. You give glucose from the other side. So you have two options. You can do either a euglycemic, hyperinsulinemic clamp. You want to maintain sugar 100 to 140, or a hyperglycemic hyperinsulinemic clamp. Both of them will give you the idea about insulin sensitivity, rather a disposition index, which will give you a good idea from that regards. So HOMA-IR as such a tool is not a good tool for patients. So a lot of people order HOMA-IR. It is not recommended. Fasting insulin and HOMA-IR is not recommended on routine clinical practice. You can use it as a research tool if you're looking at intervention or a large 3,000 patients. You can't do an insulin clamp, of course. So that's why you got doing HOMA-IR. But I would be a bit wary about that, although it shows a very good negative correlation with your BMI, trunk fat, and total fat mass.
So they also looked at the clinical parameters to take into account the environmental and family factors which may contribute to the dysglycemia and insulin resistance. They took into account the family history. At the very first visit itself, 15 years, it said they took the history of smoking and alcohol exposure and quantified it in terms of the magnitude of exposure. They also looked at the socioeconomic status of the mother, because this is basically a 3-generational study that they're looking at. So it starts with the mother. Currently, the phase that is going on is the second generation, and it plans on looking at the third generation as well. And the physical activity levels, which were again taken at 15, 17, and 24 years. They used an accelerometer initially in the form of a band that was worn for 7 days, which quantified their intensity of physical activity under sedentary times. And at the 24-hour visit, they used a band that was worn around for 4 days. So what they found was, so as you can see already in the 15, 17, and 24 years data, they started out with 3,000 patients, which by the 24-year visit were about 1,700 subjects that were followed up. As you can see, the trunk fat mass were higher in females in comparison to the males at each of these ages. With increasing age, the fat mass increased.
So, Dr. Sandeep, do you think this is unusual? The fat mass being much higher in women. Yes. So, do you expect that? Is it normal or abnormal?
Fat mass is more than, so it's around 1.5 times higher as compared to boys anyway. So what we are saying is that it was 8 and 17. So it is something like 1.5. And what is definitely more is that trunk fat mass is the one which is more. So this is something in the expected line. So if you look at our own reports, we say 20% is the upper limit of fat mass in young adults, males, and maybe up to 30% may be normal in females. So this is what it is fitting into.
And as one would expect, again, the lean mass was significantly greater in males in comparison to females, and again, it went on to increase with age.
But something is telling you that the girls had a higher prevalence of, were more adipose, besides this normal physiological variation, which is that the BMI was higher. The chances of having obesity was higher, especially in the younger age group. 15-year and 17-year girls had a higher prevalence. After that, it tended to be same.
Yes.
Carry on.
Again, the prevalence of smoking was found to be greater in females in this cohort initially, which went on to become equal in boys and girls eventually by 24 years of age. Sedentary time, again, as probably one would expect, was more in the females in comparison to the male initially in the 15 and 17-year age group. And then the gap tended to fill.
But when you say it is significant, it is 353 minutes versus 361 minutes. So this is just because your sample size is huge, you are getting that difference. So it is statistically significant, but when you are saying it's like 6 minutes, when somebody is actually sedentary for around 6 hours, so this 6 minutes will be like less than 1.5%. So I would not be that much bothered. They are similar in that regard.
And again, the moderate vigorous physical activity time was greater in males.
This we can say this is like 25% more. So this will be clinically significant also. So in general, your impression is that the girls were less physically active.
Yes.
They were having a higher tendency of having obesity. These two things I think probably is coming out of it. Any differences in terms of the other parameters like insulin sensitivity? They were all same.
We will come to that. So what they found out was that the total fat mass, I'll first start off with the graphs here. So what it shows is that your fat mass slightly increases from 15 to 17 years of age, but beyond that period, it will rapidly rise, especially in boys in comparison to the girls. The lean mass was again fairly slow progression that was seen in the study cohort, and because of your rapid increase in fat mass from 17 to 24 years, you can again see that your insulin resistance, which had dipped at 17 years, went up again.
So why do you think insulin resistance dipped at 17, Niva? Yes, so it's gone down, but what they are showing is very good that after that you benefit because you're gaining weight, you are again going up. So that is something that they are showing in that regards here.
So what it shows is your total fat mass at 15 years positively correlates with an increased risk of fat mass at 17 and then again at 24 years of age. And total fat mass at 15 years was again positively correlated with your risk of insulin resistance at 17. And it was also vice versa true where your increased insulin resistance correlated with the further increase in fat mass.
But these are all univariate analysis.
Yes.
These are not corrected correlation.
Corrected will come.
Later on, but this is just the initial.
Yes, yes.
So what you're trying to say that if your HOMA-IR is more at 15 years, you're more likely to be obese at 17. But the reason is your HOMA-IR is more at 15 because your total fat mass is more. And that is persisting.
Yeah. And the only thing is total negative correlation here because again at 17 things are dipping. Your fat mass.
And this is not significant. 0.0. Yeah, it's not significant. So Just stay there.
Sorry.
Busy one.
Huh.
So what you're trying to say essentially is that if somebody is fat at 15, he is likely to be fat at 17 and 24.
Yes.
There is a persistence which is there. If you have if you have insulin resistance or your HOMA-IR is high, you will continue to be the same.
Yes.
So there's a trend which is continuing in the same. Now, if you talk about cross linkages, you're saying that 15 years is predicting 17 HOMA-IR and 17 is predicting 24.
Yes.
This is what you're looking at. So basically, if you just summarize in one thing, if you are fat at 15, what does it mean?
That your risk of being fat at 24 is higher and your risk of insulin resistance at 24 is also higher.
I think the most important thing is that you don't want people to be obese at 15.
Yes.
15 seems to be a time when it's been imprinted. And after that, it's going to continue from there. Yes. And then they don't have the earlier levels. Because I think 15 is a bit late. They should ideally have put into somewhere around pre-pubertal age group and then maybe mid-puberty, because 15 is mostly post-puberty. So in that scenario, you will have confusion. That's the reason.
So this is again the cumulative body composition, and model 1 is the uncorrected one. Model 2 has been adjusted for sex, and model 3 is adjusted for sex and all other parameters, physical activity, your lipid levels, CRP levels, and all that. So what it tells you is again, as your total body fat has an odds ratio of 1.04 with risk of hyperglycemia through ages 15 to 24, hyperinsulinemia as well as insulin resistance. More importantly is the truncal fat marker of central obesity, which is again shown an OR of greater than 1, suggesting a positive correlation. Lean mass, as one would expect. So lean mass has shown an odds ratio of less than 1 for elevated insulin resistance and hyperinsulinemia. However, it is still positively correlated. Just 1.01 for hyperglycemia was what they found. And BMI showed similar results to the total body fat and truncal fat mass.
So what you're trying to say is that if you have got more total fat, more truncal fat, more BMI, you have more insulin resistance.
Yes.
Essentially. And lean mass is less important.
Lean mass is protective.
But not to that extent.
Not to that, yes.
Like 0.98, just on the range of it. Now, if you look at it, which of the parameter is the best predictor?
So BMI looks like the best predictor.
So I think that is of all the things that we talk about, body fat. So these are actually fat mass related by DEXA.
Yes.
So what it comes back to the whole story is that the BMI is the best marker. If you look at the odds ratio, it's 1.26, 1.19, 1.07, against 1.04, 1.09, 1.12. So I think ultimately that's what we have also found, that BMI is the best marker. We don't need to go into all that fancy things like trunk mass, total fat mass, and maybe BMI or fat mass is more important than lean mass.
Yes.
So while you want to increase your lean mass, focus should be more to decrease the fat mass. That would be the major scenario in that.
Again, because they found a positive relation of lean mass with some increase in the dysglycemia and HOMA-IR, they tried to explain it with other parameters, and they found that high lean mass also had a background of high fat mass, which probably contributed to the
which decreased the beneficial impact of lean mass.
And similarly, they also correlated the effect of triglycerides and LDL-C, which also seem to have which seem to decrease the impact of lean mass on HOMA-IR.
So what they're saying is that lean mass is having an effect on LDL, and that LDL is having an effect on that. So it's the pathway analysis. Basically, they're trying to look at whether there's a confounding factor there.
So I think the major lesson that we learned from the study that fat gain was rapid after 15 years, 17 years. So although they start off with obesity, if it persists beyond 17 years, uh, the magnitude of impact may be higher. Overall, in the study, the greater impact was seen on the boys in terms of gain in fat mass after 17 years, and that is something we need to look at. If we intervene at 15 years, long-term benefit is expected if we go by the results of these study. And again, what has emerged importantly is that BMI is a fairly accurate surrogate of body fat mass and may be a good predictor of risk of dysglycemia later
So
in
I
life.
think the main message here would be that probably they missed the bus.
Huh.
They missed the bus at 15 because at 15, your BMI is going to go down slightly. But if your BMI is less than 15, then that decrease will be much better.
Huh.
So if you want to design a school study or a school education, what would you like to do in that regard?
Probably look at children by 10 years of age to see if before the onset of puberty.
Anybody is obese pre-puberty, they are the most likely to benefit from the intervention. And then beyond mid-puberty, it will be difficult. So you want to start intervening from around 10 years and look at BMI. Don't do all the DEXA and everything. You don't need to do insulin sensitivity. But if you are able to decrease their BMI during puberty, so that by the time they are 15, their BMI is already less,
Yes.
then you will be able to achieve a better outcome, because after 17, whatever you do, your BMI is increasing. That's what they are showing.
So again, this was a prospective study. Like Sir said, it used the parameters of HOMA-IR and SPICE. SPICE is again an upcoming index. It needs greater validation in pediatric population. And probably instead of HOMA-IR, a hyperinsulinemic clamp may
Not
have been
possible.
bet,
Nobody can do that thing, because that requires admission, you have to admit, give in. So it's not possible for a population study.
And the population it looked at was all white population, Caucasian population. So if you look at the generalizability, it does not take into account Asian population who have a greater risk of truncal obesity. And I think the diet of the population was fairly homogeneous in our country because of the greater variability. It may have an impact on the risk of dysglycemia. And the impact that has emerged is that total fat mass and BMI are fairly good indicators of long-term risk of developing dysglycemia.
So I think if you say that total fat mass is also a good marker and BMI is doing better,
so
then it's a very, very clear message that there's no use, because for total fat mass, you do a DEXA.
Yes.
Now, how do you do a DEXA? The children will have to come to the hospital because it's not a portable machine. So I think whatever we have found and whatever they are showing also is that BMI is the best parameter. Don't worry too much about it. And waist circumference is the waist. This is what is emerging from many parameters of studies.
So again, total fat mass at 15 years showed a positive correlation with your long-term risk of insulin resistance. BMI emerged as a fairly accurate indicator, and probably we need longer follow-up to see how many with insulin resistance actually went on to develop dysglycemia, and what age did the dysglycemia start in this specific cohort?
What is your experience? When does dysglycemia start?
At onset of puberty is what
So
we've
we have
seen.
seen children around 10 year, 9 year also. So this is actually something which was done very late. So I think the best strategy, as you said, we can probably start off right from 5, start monitoring. If somebody is falling off the chart by 8, 10, we have to start intervention. Because otherwise things will start happening by that age. How many of them actually had dysglycemia at 15 years? Did they mention that?
Yes, they have.
Play. You have to go here, that side, and then select this. No. Select the slide.
Oh.
Select this one.
Right. Okay.
So they are saying that hyperinsulinemia, hyperglycemia was present in a few cases. Hyperinsulinism was actually present in 19.7. So that was a significant number, but that again, I wouldn't be too much bothered about. The dysglycemia was around 1%. So that was a very, very low prevalence. People who are getting overweight and obese, and the right time to pick up would be much earlier than 12 years. All of you can go through these articles, they are available, and that will be of help. You can go and have a look at our website, our courses to explore the publications, and our mobile applications in that regard. So, this has been important issue that we have been discussing about.